Oh my God, Casey, it's so good
Oh,
to see your face because I feel like we're so busy and running around and I'm like, I miss you. I
I
just
know.
miss you.
I know. I'm like, hey, can we just stay on here for about 30, 40 minutes? And Alex, you'll let us be. We'll just be in here chatting a little bit.
We'll just catch up. Like you just call me. You haven't called me in the bathtub in a long time. And
I,
so
I know. I know.
just
I'm
been,
guilty.
but you know what? I know you have, I understand you have a family. I'm not the only person in your life.
I mean, you might be. Just check your Instagram because last night I was sending you a whole bunch of Instagram. Like, oh, this is hilarious. Oh, she's gonna love this. Go ahead and look at your Instagram, and then you'll see
I
how much
haven't looked
you're
at it all day. I'll look. I'm sure I'll have a ton of entertainment, and I'll just pretend like I'm hanging out with you,
Oh,
watching all the reels you send.
yeah.
Well, I am really excited because Dr. Beck is going to be on our podcast today. Dr. Beck, the Dr. Beck.
She is so amazing. I cannot wait to go and hand her some goodies when we go visit her in her office and give her a huge hug because she is an inspiration. I really, there's no words really. I think you said legend and that just resonated, especially knowing who she is and what she's doing and what she's done. I'm in awe of her and I'm like, where were you when I was doing surrogacy? First of all, that's what I want to know. So, so excited.
I
So
always remember her because before I ever even, worked as a case manager or worked any cases with her, my friend had done an egg retrieval as an egg donor and she went to Dr. Beck and she shared a story with me. She said Dr. Beck was really thoughtful in explaining the medications that she was going to give her. And she was like, this is what I do. This is my protocol. It's different than probably what you've seen because she was an experienced egg donor. So, and the reason that I do it this way is because a lot of doctors just want to get the most eggs that they can out of you for their intended parent. And I really want to make sure that we don't hyperstim you and that you're safe and that you're comfortable. And
wow.
she took the time to explain that to her. And she told me that story and it always stuck with me that like Dr. Beck, okay, noted, mental note, Dr. Beck's a good one. So
She
I'm really
is.
excited to get to see her face today because I've never met her. You've met her so many times, but I never have.
Oh, she's amazing. I mean, so much so you have surrogates sending her flowers after they graduate, right? So that's saying something that she does. She's listening to you. And I think what resonates with me most is she says, I treat everybody the same. You are my patient. And when you come in here as a surrogate, an egg donor, as an intended parent, I'm going to meet with you and listen to where you're coming from and make sure it's safe. And I'm like, that's huge. It's key. It's necessary.
Yeah, it's sad that it's not more commonplace, but it isn't. And so I'm really grateful there's doctors like her in the world. So
Oh,
I'm really excited to get to meet her. I know she's on a tight schedule today. So here she is. Let's bring her in. Hello. How was your Thanksgiving?
I had a really great Thanksgiving, but it was also super busy at the office, but it was wonderful. So I was really grateful for our team because it's Thanksgiving is always a very busy time of year for us. A lot of patients come into town for treatment, and so I was really grateful that we had a team that was really dedicated and they were here for us and our patients.
Oh,
yay.
that's awesome.
Yeah.
And hard. It's a big ask, but I love it when everybody comes together and everybody's just on that mission to get the job done for the people that we're all helping to build their families.
100%. So thank you. Did you both enjoy a good Thanksgiving too?
We did. We actually took 3 days off. So we gave our team Wednesday, Thursday, Friday, which we haven't had that amount of days in a row off for a long period of time. So it was much needed to be able to spend some quality family time and let our team do that too. You guys were closed on Thursday, Friday? Or did you guys
My
close at all?
office?
Yeah.
So, no. So on
Yeah.
Thursday, we didn't have any retrievals, but our team always has to come in because our eggs and embryos always have to be checked every
Yeah.
day. And Friday, we had a really busy day, and Saturday, Sunday, we're busy as well. So we're up and running for both the clinic as well as the IVF lab
You're so
and the egg
amazing.
retrievals. So, yes, we were up and running 100%.
I was going to say, Casey talks about you all the time. And I know so many surrogates who have gone through your process when I was a case manager. And you are kind of a legend and kind of revered. So
Okay.
everybody raves about you. And every
That's so
time you
kind.
hear that a parent is with Dr. Beck, you just know that that surrogate's going to be in really good hands. And it's such an honor to meet you face to face.
Oh, thank you so much. That's really nice of you to say, and I'm really grateful to have this opportunity to speak with you both. So I really appreciate it. So thank you for having me.
Yeah, we were
Yeah, thank you
excited.
so much.
So, do you want to start, Dr. Beck, by introducing yourself and kind of a little
Sure.
bit about how you got into this?
Sure. So, Kelly Beck, I did my residency at NYU, and when I was in NYU as an OBGYN resident, I rotated through the fertility clinic, which is one of the top centers in New York. And when I was rotating through, I really found all the patients and the doctors so inspiring. And these are the women who really resonated with me. These are women who were delaying having children for their careers, which is what I was doing as well. So, and I also love the fact that the field was new. There was a lot of science. People were still learning. Things were changing and evolving. And I found it really exciting. So just to feel like I got to meet people who were pioneers in the field, who were starting, who were really exploring and doing the research, I think is what I found really attractive. So after my residency at NYU, I did my fellowship at Cornell to be a reproductive endocrinologist and infertility specialist. And following that, I then joined the Valley Fertility Center, which is part of NYU at the time, and helped open the office in northern New Jersey. And during that time, it was really exciting just because egg freezing at that time was still considered experimental. It really wasn't a established procedure at that time, but we were starting to have some success with having live births with frozen eggs. And so this was kind of an exciting time because I think that as we were going through the field, things are always evolving, things are changing. Growing to blastocyst was like the first big step that I saw during my training. And obviously the advent of PGD and PGS, it just kept on evolving more and more, from doing day 3 biopsies to a day 5 biopsy, from just testing multiple cells to like thousands of cells. So I felt like it was really, really an exciting time period. After, being in New York, I moved back to Los Angeles and joined California Fertility Partners, which I only interviewed in one spot. And the reason I really wanted to join California Fertility Partners is when I was in New York, this was the only group I heard about because Dr. Richard Mars was the founder, and he was the first frozen embryo baby in the United States. And I had heard so much about Dr. Guy Ringler, who was really a pioneer in gay family building and egg donor surrogacy. So I was really excited to join this team in 2009, and I'm currently now the medical director of the practice. So it's really, changed, but I love this practice, and what we do is very different than most of the practices that I know of in the area, in that, we all take care of our own patients as though we're like an old school mom and pop shop.
Yes.
We all see our own patients. There's no doctor of the day or a technician. And so I think patients, really love that. So 50% of my patients are international. It's all word of mouth. I don't do any marketing. But, I think that what they really appreciate is the fact that they're really going to get an individualized fertility assessment and care, in our practice.
Yeah. And it's so true. You guys really have that mom and pop. You've created that. And
Yeah.
I mean, when I was a case manager and I'd come to your office and be with the surrogate, that feel, and I was the surrogate through, and my first journey, actually, Dr. Ringler was my IVF doctor, so
Yeah.
I know that experience. I know that feeling. And it really was that standard that I think a lot of the clinics probably would love to strive to be. You guys have that gold standard that I see.
Right. I think the other thing that we really strive for in our practice is whether we're working with egg donors or surrogates, is we really treat every single person like their own, as though they're like a patient. And so you're not a second class citizen. Everyone's treated exactly the same. And whenever people ask me, like, do I take care of VIPs? I'm like, everyone is a VIP. We don't treat anyone differently. Everyone in our book is a VIP.
Yeah.
I love hearing that. And it's really not common for surrogates to be treated like the patient, unfortunately, at a lot of clinics. I know exactly what you're talking about. And I love that you guys have that as part of your ethos and your DNA and what you're trying to do.
I've known you, and I feel like I've worked with you, and now we're really getting to partner together. And I know a little bit of your history, but I was hoping maybe you would share a little bit of kind of your fertility story, because I know you shared a little bit of that, and love for that to kind of be shared.
Sure. So I think that, one of the things is when you are going through residency and fellowship, is kind of why I had said that this field resonated with me, is that I really understood the women who were delaying having kids for their careers and for different reasons in life. And so, I'm a planner. And so I always thought, okay, fertility is super competitive. I got the fellowship that I wanted. I got the residency that I wanted. I was going to be done with fellowship, and I was kind of planning when am I going to have my child before I start my practice. So I thought, okay, I'll get off the birth control pill and we'll have a baby. And that just didn't happen. But I think that it was really one of those things where I realized how hard it is. And, as a fertility specialist myself, what I learned is that I was working and monitoring patients all day, and I myself couldn't get monitored because where do you go? You can't get a consult. You can't leave the office. At the time, we were doing ultrasounds from 7 in the morning, and I was probably in the office till 9 p.m. every day in New York. It was just one of those things where you don't have time to take time off. So I tried to do a lot of the monitoring myself. Didn't really happen. So after about a year, I tried to do IUIs with my co-fellows. I got them to do my ultrasounds, and that was really challenging. Finally, we ended up deciding we were going to do IVF. And what was really hard is that I had done the HSG at another center. I had tried to see another doctor at another center. The problem was that there was no anonymity. So even though we have HIPAA and we're not supposed to share a medical, everyone's supposed to be very private. The problem was that everyone knew who I was, and I felt like, to a certain degree, I felt like I had no privacy. There was no way I was able to hide myself. My husband's also really tall. He's 6'8". So it's really hard to get him in and out of an office ever without him being seen. So it was really a challenge. But when I did do IVF, I was really glad that I did go through that process, but it took me about 2 years before I finally decided to do IVF. And when I did do IVF, fortunately, it worked. But, back then we couldn't do testing of embryos. We were biopsying on the third day. You can only test for 3 chromosomes. I wasn't comfortable with losing about 12% of the embryo and not knowing if the embryo would survive or not. Wasn't comfortable with the technology at that time. This is 18 years ago.
Yeah.
And so when I did do the transfer, I actually put in 2 embryos. And the physicians I was working with actually didn't want to do a transfer because I kind of had mild OHSS. And they said, you know that if you were the doctor and you were treating this patient, you wouldn't do a transfer because of the higher risk of ovarian hyperstim. And I said, we're putting it in. We're going to put in 2 embryos. So I forced their hand. I did my 2 transfers, and I ended up with twins. I was really fortunate and lucky. But I have to tell you, it felt really hard because I kept it a secret. I was pregnant with twins. I worked until 38 weeks and 5 days.
Oh my
But
God.
up until about 29 to 30 weeks, it was interesting. I worked full time, no problem. And, we were so busy at the fertility practice that I was at that there were days where we were doing 20 retrievals, 20 transfers a day. So I would go over to try to do the procedures and help transport patients. And I remember one day, one of the doctors said, I think you're kind of gaining a lot of weight. And I said, oh no, I'm actually pregnant. But I didn't tell them I was pregnant with twins. And so I ended up delivering it 38 weeks and 5 days. I think I worked until 38 weeks. And at 30, I had a scheduled C-section at 39 weeks, but at 38 and 5, my water broke. And, when people were coming to visit me in the hospital, they couldn't believe that I had twins. And then, of course, everyone wanted to know, did Kelly do fertility? How did this happen? How did she have twins? But I had made myself an AKA, so no one could find me on the computer system. But it was just kind of an interesting thing. But I do realize, how back then fertility wasn't at the forefront, where people were really talking about doing IVF. It was still pretty hush-hush. I think nowadays people are much more open about, sharing their fertility journey, and if they're going through IVF or, having an assessment with a fertility specialist. But I think also with the advent of egg and embryo harvesting for the future, it's a much more common topic and it's not so hidden.
Yeah.
But, after I had my twins, it was interesting because I did find that it was a kind of a great experience, but it gave me so much insight into the field. And I think that's why I probably practice differently as a physician. When the twins were 6 months old, I conceived my little one who's 16 months apart from the twins on birth control pills. I was studying for the boards. And it's one of those things where, what you were saying earlier, Casey, it's kind of one of those things where you least expect it. And I wasn't getting my period, but I never got my period because I'm under so much stress that there's many times I just skip my cycle and it didn't think much of it. But surprisingly, I only discovered I was pregnant about 12 weeks into the pregnancy. I was about to go to a wedding, and when I found out I was going to go to the wedding, I wanted to make sure that I didn't have a really heavy menstrual period at the wedding. So I checked my hormone levels in the office. And I remember the person who drew my blood said, Dr. Baek, your estrogen's over 20,000. And the first thought I had is, oh my God, I have ovarian cancer. And she's like, no, you're pregnant. And so it was kind of embarrassing as a fertility specialist to not know I was pregnant, and I was 12 weeks. And then I got a lot of different consultations from high-risk OB specialists to find out whether or not if everything was okay with this pregnancy, because not knowing I was pregnant, I was doing a lot of hysterosalpingograms where you're exposed to radiation. And even though you're wearing lead, I wouldn't have done that for the entire first trimester. I also, to be honest, was drinking alcohol. My twins were young, and I would have a glass of wine every once in a while. And so I wanted to make sure the baby was going to be okay. And he's actually, everything turned out to be fine, but it was a very stressful period.
So you were working such long days, working so hard, raising twins, pregnant again, and then you have 3 little ones that are all in diapers at the same time. Like, you are
A legend.
such a superwoman that I know part of the things that I was learning about you is that you're really involved in a lot of women's advocacy, and I think it sounds like you have experienced a lot of even just struggle probably in medicine in general. It's a very male dominated field, and even with infertility and so much of it being work on women's bodies and in women's bodies, not having as many women in the room is such a challenge. I'd love to hear how that inspired you to take on some of this advocacy and what you do to promote women being involved in
Sure.
this space.
So when I was going to fertility, the fellowship at the time, there were 24 positions nationally. So it was a very hyper competitive field. And at that time, I knew that if I even spoke about pregnancy or was pregnant, it would be really challenging to get a fellowship position, which is why I was on birth control pills. And I remember, I'm not going to name the center, but there was a center very prominent where I interviewed for the fellowship position. And one of the interviewers asked me, I know I'm not allowed to ask you, but are you planning on having kids? Because they wanted to know if I was going to get pregnant during the fellowship, which obviously would have affected if they were going to rank me highly or not. But it was kind of eye-opening at that time that I really was careful, which was why I delayed. I was really made sure that I didn't get pregnant during that time, and I stayed on birth control pills, and I really did delay having children. But I think that when you're going through the field and then you're looking for a position for a job, you do, unfortunately, I felt at the time that I had to keep it hush hush because I did think it would affect my ability to find a job if I told people I was trying to have a baby or if I was pregnant. And so that was one that I did find challenging. But I do feel that nowadays there's so many more women in our field. I think it's a really completely different, environment to have children in residency, fellowship, and even in practice, which I don't think was the case about 20 years ago. But I think that one of the things that I really appreciated was I had a very strong female mentor when I was a resident. And so even when I was at a different center for my fellowship, she remained my mentor, and she's now one of my closest friends. But what I found was how important having that female mentorship was. And so I think that as I have gone on to practice and was an attending, I really made an effort to try to kind of pay it forward, mentor women, and to try to help them find that balance of just not just for their career, but also for their family and relationships and life, and how to start a practice and what are you asking for. A lot of times when people come out of any type of training, they're just so excited to be offered a job. They don't try to negotiate. So I think I really tried my best to teach them like things that helped me or with the mistakes that I made so that they wouldn't make the same mistakes. So I'm on in a group called Visionary Women. And in that Visionary Women, it's all about women. And so we support, and 100% of our donations go directly to women organizations. But one of the biggest things that I love about it is that when you're at that organization, most of the women who are there are successful. But we now have women who are in high school, college, who are starting out, and we have mentorship programs where kind of the women who are older and have kind of achieved some success in their field are mentoring women who are entering in that field at a younger, they're just coming out of training or starting a practice. So I've tried to mentor a lot of younger women, whether they're starting a practice in clinical or any type of medicine.
Those young women, I wonder if they have any idea how lucky they are to have a bunch of seasoned, experienced, professional, successful women reaching down and pulling them up. That's such a gift.
Yeah.
No, but I think that if you ever are in Los Angeles and we have our monthly meetings, you really should come because I find it really empowering. And what I think what's empowering is because everyone from above is kind and really tries to support everyone who's younger or starting out. I think that it really creates that environment. And so there's a no tolerance for any cattiness or people who aren't there to help.
Oh, you count me in. I want to be there. I
I
mean, I'm
know.
already
When is
like,
the
how do
meeting?
I
I'm on my
be part of
way.
it?
100%. Yeah, so that is like why I really feel strongly about it. And so I participate in their leadership retreats. I went to my first one last year and I learned so much. And it wasn't about what you learn on that leadership retreat, like in terms of lectures. It was simply about meeting 30 women from all different fields, and you just sitting them with them on the shuttles for each ride, or like sitting next to them for meals. You learn so much about everyone, and I think when people are open and they're really there to share, and there's no ego, it's really you realize how empowering and how much we can help.
Yeah, I love
There's
that.
really not enough of that. And I think women are often encouraged to pit themselves against other women rather than to work together. And we are so much more powerful when we are working together and lifting each other up. And having somebody set that tone early for younger women is so cool because those women are going to grow up and follow that example and empower more women. It's just going to have such a tremendous ripple effect. That's a really awesome thing to be a part of. That's so cool.
Yeah, so we have a physician who joined us in October, Dr. Nina Vias, and she trained where I trained at Cornell. And what I really love is that she had a baby and she was able to delay having a starting in our practice, so that she could have her baby and enjoy that time. And I think that's something that really was kind of unheard of 20 years ago. So I was really happy she had that time. And what I really love is that my other partner, Dr. Corinne Chung, who was actually did residency with me at NYU, and then she ended up doing her fellowship at University of Pennsylvania. I think even though we had been here for over 20 years, what we found is that we really realized like what she's going through, having a baby right now when she's building her practice. I think she's having a different experience, hopefully, than what we had when we kind of had to just kind of go start your practice. Because I remember I had my C-section, I had the twins, I went back to work full time after a month, and it was a challenge. But the only reason I was able to do it was I had a really great support system at home. We hired a lot of people to help, and obviously I have no shame in my game, but I did have a lot of nannies and I had a lot of help. But that was the only way to function when you have 3 kids under 2.
Yeah.
Yeah. And when you have such a demanding career and you don't want to give up any of it, and if you have the ability to have help so that you can keep doing what you're doing and not sacrifice what you've worked so hard for and still have your babies that you love. But even with help, it's so hard. It's so hard to be a mom
Yeah.
and to be a career driven woman. Even if you have all the help in the world, it's hard. So I think it's awesome that you guys are promoting helping women find that support system. And
Right.
we know how that how that can be. I know my love Casey, she when we started Surrogacy Is together, she had a little baby. Trinity was how old? What, a year and a half or almost
Yep.
2? And
Right.
then she had Talia shortly after, and she's doing this. And I'm like, I just don't know how you're doing it. I don't know. I have a puppy and I'm overwhelmed.
Well, and I have 2 big. So I have an 18-year-old, almost 18-year-old, and a 17-year-old. So I kind of did where I had my first 2 early on and then was able to help a family through surrogacy. And then went to my husband and said, I don't think I'm done. I want a baby again. And he's like, what? We're so close to the finish line. And we had already started kind of our careers in our life and just kind of where we were going, but it was tugging on my heart. And I just said, okay, I think we need to do this. And I have my babysitter downstairs right now as we speak, because we do it, right? We make the thing happen.
Yeah.
Sunshine and I, we're so passionate about what we're doing and bringing forth education. And this process means so much to us that we can do all the things. We can be inspiring, empowering women that can be moms and wives and also career women. And I think that like you're a testimony to that, Dr. Baek. And I am just so grateful that we've been able to have this conversation and get to know you. We already thought you were a legend. Now I'm just like in awe of you right
No,
now, quite literally in awe of you. So
no.
thank you, really, truly. Because it starts with you
But
guys.
I
It
think
starts with you guys being able to bring forth the ability that we can do this. It's a team effort. It's us all standing up to say, yeah, we have the ability to bring forth change.
I'm
So
going to do my part and help and help somebody achieve their dream. And I think something that people don't think about a lot is for women who choose to be surrogates, they really are givers and they love and care about helping people build their families. And they also are typically women who are maybe stay-at-home moms or are not really but they have goals, and so the compensation for surrogacy allows them to level up in ways that they wouldn't have the opportunity to otherwise. So they're being empowered with their ability to carry a pregnancy, and that they've done that for themselves and for their own families already, and now there's maybe things that they want to make possible for their children that they can't without a little bit of extra help, and so they're able to use their gift to help someone build their family. And I have met so many women that started out as first time surrogates. And I feel like at the end of their journeys, they're so different because they're so proud of what they've accomplished, because we put ourselves
hmm
through a lot to go through IVF and some failed transfers and sometimes chemical pregnancies or even late losses, and then come back and go back to it and do it again and do another med cycle and try again, because we want to get these parents to the finish line, and we said we were going to do it, and we want to follow through and help them have a baby. And I think the women who sign up to do surrogacy are so special in that, and they just come out stronger on the other end of it, I think, from what I've seen in my experience. Do you get to interact with surrogates a lot after the beginning, or do you just get to meet them in the beginning?
So I usually meet them in the beginning, but I do have several surrogates who've done repeat,
Mm.
so, Germany's, even if it's with different parents. And it's really nice. And we're always honored when they actually request to come back to our practice, where they will request, certain physicians. And so they come back to our practice, and it's always nice to see them again. But I do find it to be really like, it's such an honor when you have a surrogate who's willing to do this for another family, because they're putting themselves at risk. And I always tell patients the reason I will not do social surrogacy, so I won't do surrogacy unless there's a medical need, is that they're putting their health at risk. Bad things can happen in pregnancy, even if you've had perfect deliveries. You can have high blood pressure, diabetes, preterm labor. You could hemorrhage. You could lose your uterus. And so, these are things that I'm not willing to risk. And so, if we do it, that's why we really require. I know that patients always ask why we don't do social surrogacy, and that's really why. Is that you have another human being who's putting themselves at risk to do this for you, and so there has to be a medical indication that's our practice protocol and
yeah, I
philosophy
love that. I
Across the
appreciate it.
board at CFP? That's for all physicians here?
across the board.
I didn't
Yes.
know that. But that makes a lot of
Yeah.
sense. I know there's a lot of debate about that, and I get it, reasons why people don't want to carry their own pregnancies for other reasons. And I think to each their own, but a lot of times surrogates are not informed about the reason. And I think if a surrogate's going to put herself at risk, she should be fully informed of the risks that she's taking and the reasons why. Because sometimes surrogates might assume that the parent has a medical need and they don't know that they're doing it for another reason. And I think that's so important to
Right.
disclose that so that they can be empowered to make that decision for themselves.
I think whenever we're working with surrogates, one of the things we impress upon parents is that you have to be transparent. And so if they are still trying on their own, just be open about it. Like surrogates are going to understand, like they're going to understand you want to have children. This is why you're pursuing all fertility treatment. So they're going to understand. Or if you decide that you want to get two surrogates, fine, but just tell everyone this is what you're doing, because I think the last thing you want is for someone to feel that you're holding something back. And if you're transferring a low level mosaic embryo, in our practice, everyone has to be informed, they have to be counseled, because they have to understand if you do a low level mosaic embryo, it does result in a pregnancy 30% of the time in our lab. But the surrogate will most likely need an amniocentesis just to ensure that the embryo is normal, that the normal cell line propagated is not the abnormal cell line. So if it turns out it's not normal, they may need to undergo a termination if that's what the intended parents want. So that's why we really feel that counseling transparency is really key to any relationship, because I always tell patients the reason you have to match well with who you have in a surrogate, you have to be really honest. What are you looking for? Are you looking purely for a business transaction, or are you looking for someone who's going to be a part of the extended family? Like, what type of relationship are you looking for? Are you going to go to the different doctor's visits, or do you just want to pick and choose when, or do you just want to go to the hospital and pick up the baby at the
Yeah.
end? Because if it's not well matched, then it's a very, very difficult 10 months.
Yes. 100%.
At least 10 months, right? Yeah. And you need,
Right.
there's not a relationship out there that needs more trust than the relationship between
Right.
surrogate and intended parent, I think is, and when that trust is broken, it's really hard to repair. And then what do? You're stuck. If there's a baby on the way and surrogate's feeling like she's been lied to, and she's got to carry the baby and see it through to the end. And then when those things happen, when those matches are pushed forward that are not thoughtful, or when somebody heard that little voice that was like, I don't know, something's not right, or I'm going to just ignore, I really wanted this, but I don't want to wait. So I'm just going to match. It almost always comes back, that voice that you ignored. You hear it again later and louder, and you remember why. You have to listen to your instincts
Yeah.
and really trust.
100%. I mean, I'm sure you were both probably experienced it, but during COVID, at the very beginning of COVID, when we were going through the lockdown and people had surrogates who were pregnant, I mean, the anxiety level for everyone involved was like so high. And then the whole idea of vaccination or no vaccination, I mean, it was such a trying period for everyone. But I did find that when you have, a lot of transparency and trust, it was a much easier conversation to ask surrogates, please do not leave the home. Please stay home. Because at the time, we don't know what's safe yet. And, when we're having the conversation, we're not saying, like, this is what you must do, but we just don't know enough. We just want to make sure that everyone's safe. But, that was really a time when you realize how critical it was, and how, I was so grateful that we really focused on having that transparency and trust, because it made everyone who was going through a transfer or had a pregnancy during COVID, how important it was that that was already established, so that, intended parents didn't have such a challenging time. It was challenging for
Right.
everyone, but it wasn't as bad as it could have
Sure.
been.
Yeah.
So, one of the things that we hear about your practice specifically is, and in surrogacy in general, a lot of times women that apply, they really want to do surrogacy and they get their heart set on it. And there are so many qualifications that very few women who want to do this actually qualify to do it. And they get disappointed and they take it personally sometimes. But I would love to hear your perspective if you could share for these women, because I think anybody who wants to do surrogacy and really from their heart wants to sign up to do this, even if they don't qualify, they're so special for even having had the desire and for raising their hand to say, like, can I do this? Even if the answer is no, it's not safe for you. I'd love to hear your perspective on why the requirements are what they are. And I know you have even a little bit more strict BMI requirement than some doctors. And people always wonder, I've had babies. This is my BMI. I had perfectly healthy pregnancies. How come this disqualifies me? So I'd love to hear you share about those requirements and why they're in place.
Sure. So whenever I am reviewing a surrogate profile and the records, I actually always look directly to the obstetric and prenatal records, because sometimes it's not intentional, but surrogates may not realize that, oh, my blood pressure was running high throughout the entire pregnancy, or the doctors wrote that I had elevated high blood pressure or that, is spilling sugar, and they had no idea. And so the things that we look for really are there elevated blood pressures in pregnancy? Is there any sign of gestational diabetes in pregnancy? Is there any preterm delivery or complications or scarring or any type of complications in pregnancy? And why is that? If you have a history of high blood pressure in pregnancy or preeclampsia or gestational diabetes or preterm labor, you're at a much higher risk of having that again in a future pregnancy and even at an earlier gestation. So someone who may have had it in their third trimester sometimes can have it earlier in like their second trimester, or they could have intrauterine growth restriction. So that's number one. And it's not really just only for the pregnancy, but it's also for the surrogate's health. These are things that they themselves need to know, like, look, you're at a higher risk and you were signing up for something that's much riskier than you probably anticipated. So you need to know what you're walking into, because the last thing you want is for someone to get sick or have a really, bad outcome in pregnancy, which could have been avoided. So that's number one. Number two is if they've had more than 2 C-sections. Anytime you have a cesarean section, sometimes that cesarean section doesn't heal well. And you can't see it at the start when they're menstruating. You can't see it after ovulation, but around the time of ovulation, sometimes you'll see, that a patient's C-section scar may have a defect in it where there's a slight separation. It's called an isthmocele. An isthmocele is where there's a fluid pocket, and I've diagnosed this in a couple of women who've only had even one C-section, and it's the way their body heals. You can have the best surgeon, but it's how your body happened to heal. Why is that important? If you are pregnant and this is undiagnosed, not only does it risk intrauterine growth restriction, preterm labor and delivery, but you can have a uterine rupture. And if you have a uterine rupture, that is a major emergency, and both the surrogate and the baby may not make it. So this is like something that can be missed. So that's why we limit the number of cesarean sections. And I have to say, I've seen this on occasion, even with people who've just had the history of one. And that's why we try to not have more than 2 C-sections.
I love knowing that.
Yeah, and people will say, well, what? No one else saw that. Well, it's not because they weren't looking for it. It's at what time of the menstrual cycle that they're seeing you. If you're seeing it at the beginning, it's when the estrogen level is mid-cycle, before ovulation. That's when you see that cervical mucus. That's when you can see that C-section separation with the fluid buildup, and that's really when you can diagnose it. The other things that we look for are BMI. The reason is when there's a higher BMI, it is associated with lower pregnancy and higher miscarriage risk. And sure, if you're doing it for your own pregnancy, you'll assume those risks. But if someone can't carry for themselves and they have one embryo and they want to give that embryo the best chance, that's really why my criteria is stricter, is that we know that women who are over 25 is, overweight, but over 30, it's obese. And we don't want, certainly not morbid obesity either, because there's complications to the pregnancy and to the patient themselves. So that's really why the BMI restrictions are happening. And so I think it's mainly obstetric delivery records, the number of C-sections, and then the number of pregnancies. Why do I really try to have women who only had 4 deliveries and not 5? After 5 deliveries, you're actually considered a grand multip. A grand multiparous patient is someone who, even if they've had 5 uncomplicated pregnancies, the data has shown that they're at a much higher risk of having postpartum hemorrhage, intrauterine growth restriction, and complications in pregnancy. That's why we limit the number of pregnancies or deliveries, not pregnancies, but deliveries. And then I'm trying to remember if there's anything else I'm missing. And then in terms of medication, what medications are they on? So if they had depression and they're on an antidepressant for a situational, that's perfectly fine. But if they're on certain medications that are not safe in pregnancy, if it's for yourself and the benefit outweighs the risk and you're on seizure meds, sure, you'll take it. But if it's for a surrogate, that's really not. It's something that the intended parent has to be comfortable with, and oftentimes they will not. We will get a medical maternal fetal medicine consult to see what they recommend. I have had patients where if they've had a fetal demise of their own, and they'll say it was a cord accident, we just have to have documentation, have medical maternal fetal medicine, do a consultation and confirm that really there's no other reason for that loss and they really would be an appropriate surrogate.
Yeah, makes sense. I've learned so much right now, Dr. Beck. I've heard sometimes with correlation to the BMI, if it's higher, that there may be less likelihood that the medication responds as well with your body going through the IVF cycle. Is that also something that plays in?
I haven't seen that as much, mainly because we are when because we're using intramuscular progesterone injections. I really haven't seen
Okay.
that, and so I haven't noticed that. I'm not sure exactly how that would correlate. But whenever I do a cycle, even if it's a first time or a repeat surrogate, I do a mock cycle. And the reason for that is I do want to do a test run to make sure they're absorbing the estrogen progesterone well. And believe it or not, I've switched over from doing injectable estrogen and progesterone, doing estrogen patches and progesterone. And I'll tell you why. I don't know if you've seen this kind of across the board more frequently. Have you seen this,
A
Casey,
little
with
bit.
your
Yeah, we have seen a little bit, but I'd love to hear your perspective on.
You know
No, I
why?
don't. No,
Okay. Okay, I'll tell you
please.
why. There's less risk of having a medication error because the
Ah,
syringes that you use for the estrogen is different than the progesterone. And if it's a first time or repeat, they are trying to do their very, very best. But sometimes it can be confusing and they'll mix the syringes and then there will be a medication error and then the cycle is lost. So that's number one. Number two, what we found is that the reason I like the estrogen patches over the estrogen and oral estrogen, and that's just my personal preference, is when you take oral estrogen, it gets metabolized by your GI system. So a lot of women will complain of having like nausea or not feeling well. Whereas with the estrogen patch, it bypasses your GI system. And so you can't have nausea. And it affects really well. And there isn't that highs and lows of what you ate that day, but it's a very consistent level. And I found that even though the estrogen blood levels may not be as high, the the lining looks beautiful. And I've done enough uterine biopsies where I send it to Yale with something called the endometrial function test. I do not do this in surrogates, but I've done it for patients. I found that even with low estrogen blood levels, the correlation is not great with the estrogen patch, but it still is effective at the level of the uterine lining. So I don't need high levels. And I know that I've seen some patients where when I look at the previous records, they're on both estrogen and estrogen patches, progesterone suppositories and progesterone injections. It's like too much medication. Like I have no idea. So I
That's what
definitely am
I
like
always had.
less
I
is
always
more.
had like I feel like they threw the book at me in all of my journeys. They were
I
like,
know.
everything we can
Right. So
prescribe, here you go.
yeah, so I'm definitely a less is more person.
Where were you
And
when
I
I
think
was doing this? That's what I want to know.
so I'm moving more over to the estrogen patch, and then for the progesterone, obviously the main reason we use injections in patients in surrogates, but not in patients, is in surrogates. Most of the surrogates are not local, and the only way we're able to monitor progesterone is by the blood levels, and it correlates better with the progesterone injections. But it's not something that if they were local, would I be opposed to trying a progesterone vaginal suppository? No, absolutely not. I've done it before with surrogates. It's just that they need to be local because we have to be able to monitor it better because it doesn't correlate as well with the blood levels.
Gosh.
But we found that it can be just as effective because that's in my patients. I do not use injections. I only use suppositories because I found them to be just as effective.
Wow. I've learned so much today. My mind is just, this is so informative and I
I
think
know. I feel
necessary
like
for everybody to
you know,
hear.
you always learn so much, and then you're like, wow, gosh, I don't understand anything. And the more I learn, the less I feel like I
No, it's
know.
it's really interesting, but I definitely it's one of those things. So there's this lab at Yale. His name is Dr. Harvey. I don't know if you've heard of Harvey Kleiman. He's at Yale. It's with the endometrial function. He does recurrent pregnancy losses. He has a great placenta lab, and he has a great like recurrent pregnancy loss lab at Yale. And so that's where I do for patients, not for surrogates. We will do a mock cycle and we'll send it off there. And what we found is that a lot of women who have recurrent pregnancy loss or recurrent implantation failure, it's oftentimes that they're getting too much medication. So instead of starting off at 200 milligrams of suppositories, I start off at 25 milligrams, which is 1/8 the amount. Some require 12 and a half, which is 1/16, or even 6 milligrams, which is like nuts. It's like barely any progesterone, but that's really the key to finding the right sweet spot for that patient. And so you realize you don't have to correlate with the blood because you really care about what's happening on a microscopic level in the uterine lining.
Wow. I love it. It's so
Fascinating.
fascinating. Yeah.
Yeah, I think because I've done a lot of that for my patients, that's why I'm definitely lighter with the meds with surrogates because I realize we really don't need to use a lot of meds and it works just as
Yeah.
well.
And just to think of what we are going to explore and learn just in, 5 years, 10 years time, where we'll be in the future with this is really neat too. And I'm
Are
so
there
excited to be
any
part of it.
are there any breakthroughs that you are studying or looking into right now as far as fertility medicine that you're excited about for the future?
I'm always trying to figure out like what is the next breakthrough. So, we had the egg freezing. Prior to egg freezing, before that it was the whole ICSI where you inject the sperm into the egg, and then there were the big movements towards PGD where you're biopsying embryos and seeing whether or not they're genetically normal. I do think the big movement towards, and I don't know if we're going to get there, but the hope is to be able to find non-invasive ways to be able to detect whether or not an embryo is genetically normal. So I'm sure you've seen that the studies where people are testing the media that the embryos are culturing in to see whether or not there's a correlation between that and whether or not the embryo is genetically normal. We haven't gotten there yet, but it would be so amazing. And I'm sure you've seen all those time elapse cameras that they were putting in incubators. Unfortunately, none of those things worked. But, people are striving. So I think that that's really the next step is to try to find a non-invasive way to determine which is going to be a genetically normal embryo for us to
That's
transfer.
so good.
Yeah, we heard about that testing the fluid because the embryo's like shedding cells and so they can test that without damaging because that is the risk of testing the embryos, right? Is damaging the embryos and them not surviving.
So what we found is one of the reasons I actually don't accept outside embryos because people always want to know why I won't do it is because every lab is different in their criteria for what they will biopsy. And I feel that if it's not structurally normal or it's a high grade, it won't result in a baby. So it has to be structurally normal and genetically normal to result in a baby. That's number one. But what we found is that if you have a structurally normal embryo, it will survive that biopsy and freeze well. So whenever people say, oh, is it going to damage the embryo? It's only going to damage and compromise an embryo that wasn't
Mm.
structurally normal. If you have a structurally normal embryo, it will not affect it. One of the things that we do in our lab is we do something called a no-look continuous culture. So we look at fertilization, then we don't look for 5 to 7 days. And the reason for that is we first did an internal study. And what we found is that by not disturbing the embryos, without pH, temperature, and gas exchanges, where the embryo has to like recalibrate, embryos develop better. And we were getting a lot higher blast rates and getting higher genetically normal embryos. And I think it's just you're minimizing the stressors to that embryo.
Yeah. Wow.
Just leave them alone.
Yeah.
Yeah, so I think that like we're definitely learning that the more you leave them alone, the better, which is why I think that the next phase of like what the next breakthrough will be is if we can find a way to do non-invasive testing.
So good. So good. Thank you so much for letting us just explore and learn through this. And I think we'll need you on again at some point. I just feel it.
I would love that. No, I really enjoyed this. I really, I hope I shared something new because I know you guys have both been in this field for a really long time and you probably have heard a lot of this already before, but thanks for letting me share it
No,
again.
so
Every
much.
every doctor has their unique perspective and their things that they love and that they are fascinated by in this field and it's such a interesting there's so many diverse perspectives. So I love hearing what your focus has been and thank you so much for giving us this time. I know we're coming up to your hard stop because you've got things to do, but is there anything that you wanted to share or anyone to take away from this before we wrap up?
Yeah, I think that, whenever one of the biggest things that I see with my intended parents when they're working with the surrogate is there's a huge moment where they have to just give up. They kind of have to mourn the moment that they're not going to carry the baby because no one imagines that they're going to have someone else carry the baby. Everyone always pictures themselves pregnant. They have like that moment where they think like, oh, this is what I'm going to look like when I'm pregnant, what it's going to be like to have a child. So that's one. But I think that the other thing that I really love for patients to understand is that there's so many ways to build a family. And so even though this may not be how you anticipated it, it's something that, we're so fortunate we have this as an opportunity and an option, not in every state, but it's still an option. So I think that like for patients to really embrace it, because I know that a lot of times for patients, the biggest hurdle is trust. And one of the things I really have to go through is, these are women who want to do this to help you. It's not because they need to do it. There are many other ways to do things safely and not put their health at risk. And so I think that when you realize like people are grateful for each other, that it's a much better relationship. And it's kind of one of those things where people appreciate the opportunity to have a surrogate. And I think it also makes the entire pregnancy a much more joyful experience for everyone.
Yeah.
Thank you
So
so much for
good.
sharing that perspective.
Thank you.